Can you all? Oh, yeah, you can all hear me all right, can't you? Good morning, everybody. Thanks for coming, sticking around for Saturday morning. Um, my name's Tina Rossler. I'm the Director of Clinical and Business Development for BodyPoint. And my compatriot over here,
Was going to try to advance this slide.
oh,
There we go.
sorry.
So my name's Christy Hamstra, and I'm a physical therapist, and I work for Motion Composites. So those are our disclaimers.
Yes, and today we're going to talk to you about equipment and stroke, or stroke and equipment provision, not stroke and not the opposite. I think one of the things that we have looked at over time is that Christy and I in the field and even in our roles at the manufacturers have realized that often the stroke population seems to be a little bit forgotten. Not necessarily forgotten, but kind of maybe neglected.
Yeah, kind of brushed to the side maybe a little bit, or
Um,
underserved. Underserved,
yes,
I think, is a good way to put it.
definitely underserved. So we want to look at some of the barriers that we see and why assistive technology isn't being necessarily provided in the most appropriate way sometimes. I'm looking at supporting justification and also identifying recovery outcomes that can be enhanced with the use of appropriate equipment. It sounds really basic and things we should know, but it's not what we're seeing out in the field. So I want to go over a little bit the statistics of stroke because I think when I started looking into this, it's some of the numbers surprised me. So over 12.2 million new strokes every year worldwide. That's a huge number, right? The number that surprised me though was it's about 50-50 more or less men to women. Actually, slightly more women have strokes than men. And also the age. 53% of strokes happen in individuals who are under the age of 70 years old. How many of you always think of stroke and think of it as an old person problem? Most of us don't because we've practiced, but a lot of us do, right? The first thing that comes to people says, oh, they had a stroke, they must be old. We know that's not true. There's actually been some high profile individuals who've had strokes in the last few years that were actually quite young. So it's a population that is really underserved again, and the statistics are pretty surprising. When you look at people who are permanently disabled after stroke, because we have been better at quick treatment and intervention, is about 15 to 30%. Now, this does vary country to country, region to region, based on access to healthcare. So when you look at the worldwide uh, statistics, China, for example, 45% of people who survive from stroke are permanently disabled because they may not have access in different areas to healthcare. Make sense? And they do not define the type of disability. So while we are specifically looking at people who are non-ambulatory or partially ambulatory, maybe, the statistics don't tell us what percentage of that 2 to 4 million are using wheelchairs or not. So, what does the research say about intervention? Hopefully, it doesn't say this.
Right. So I'm sure we've all seen people looking like this.
And if you do a search on Google for equipment for stroke,
That's what comes up.
ta-da! Um, so what does it say? Most of the research says one, upper extremity support, always necessary. We often see people with no or poor upper extremity support. It also says early intervention is key. There are hundreds of studies. Even a study that compiled all of the studies said you need to start now. You need to start at acute onset. Don't wait until outpatient. Don't wait until even rehab. Start in acute care once they are medically stable. So any kind of intervention for the upper extremity, for seating and positioning, for recovery needs to start sooner than later. The other thing that was really interesting, there were two studies that looked at technology for stroke and showed that there was a huge lack of knowledge and education about the utilization of existing technology, both from the caregivers, the therapists, and the physicians. And we'll review some of those as we go along. Does that surprise you a little bit? So, what's common practice?
Well, I think we all know that we have to get the client medically stable, right? Who in this room, I'm going to assume almost every hand is going to go up, has treated someone with a stroke, knows someone that's had a stroke? Nobody's going to give me hands this morning. Thank you. Thank you. Sorry. You can fall asleep. It really is okay. I realize we're all in that position, but we need to get them medically stabilized. So the recommendations are, let's give them proper positioning. But again, it's very limited as to kind of what that proper positioning is. Let's position or support the upper extremity. Fine, that's great. Really vague recommendations as to what is the recommended equipment or assistive technology. Both Tina and I spent some time while we were presenting or preparing for this presentation, looking at evidence and trying to see kind of what was there. There's unfortunately the rapid push to discharge home with caregiver assistance, or rapid push to go into some sort of a care facility, right? And when that happens, then usually it's just the standard wheelchair that's provided. More so maybe in the States than in some other areas, but there's also then what if? And so we are constantly in the, well, what if they're going to get all this recovery? Why should we spend all this time getting there something that's custom or that's going to work really well for them? So what is that assumption of recovery, and what do we and how do we play a role in that process?
I have a question. Oh, sorry. I have a question for you all. How many of you at your facilities, if you treat stroke, have a guideline for intervention? Any of you? And have you read that guideline of late?
Did you
So
see? I didn't see anyone raise their hand
I
because
had one.
Oh,
I had one.
can you share it with us after this? That'd be great.
So when we looked up online, I found probably 6 or 7 different hospital-based guidelines for stroke rehabilitation for the facilities. All of them just said position the person and showed pictures of people lying in bed with pillows.
Yep.
That was it. So it really is kind of pervasive that we don't really have this path to best practice.
And so here, again, if you just do a Google search for upper extremity support or stroke support or anything like this, these are the things that you're going to see. And I'm sure a lot of us have seen some of these. I would say, maybe the first two are a little bit better than some of the others. But hopefully by the time we're done with this, we'll at least have a few more ideas or some maybe even products that we could use in place of some of these things. So here are some actual clients using some of the things when both Tina and I would run into these clients. So we're going to go through the first two as case examples. So you will see pretty significant span of the treatment or the assistive technology for the first two clients. But we got a sling. We often sometimes see that just in a sling. That's not going to be great. It's going to cause decreases in range of motion. We're going to have all sorts of issues with that. The next one, that PVC kind of, or that plastic there with the towel. It's pretty optimum there. And then the one there on the far right is Tina's client. So
yeah, client from another facility, but this was.
Are you off?
But she didn't have the correct intervention. You can see that. We'll see another picture of her later.
Just leave it on.
Sorry.
We can talk over each other. It's okay.
Yeah.
Nobody will care.
So we do have the tools to do better. So the research was kind of surprising to me. So it was specifically related some to upper extremity, but also to abandonment of equipment. And it showed that when you look at, for example, dynamic arm supports for people with strokes or other disabilities, that there were literally 104 different dynamic arm supports on the market that these researchers were able to identify and find, but they were rarely used because there was very little knowledge about them. So sometimes that's a bad on us as therapists, or a bad on the ATPs, or just a bad on us as an industry in general for not making sure that this information is available and we know what's available out there. That number kind of surprised me. They said there were 104. And then also they looked at specifically for upper limb and recovery with tetraplegia. They showed that there were a lot of devices that could be used, but upper limb recovery wasn't given priority. So often they weren't used, but when they were utilized and utilized appropriately, recovery was greater. It makes complete sense, but kind of shows that sometimes we get kind of focused in what we need to get done and we need to get it done quickly We need to discharge these folks. And we forget what options are out there. So I think some of it's a little bit up to us, unfortunately, to kind of find out what is available to us, what can be provided, and where do I find it. Other barriers to equipment provision. We want to talk about this and we're going to go through it and kind of dispel some of the myths that surround that. So we're going to go through each of these. We're going to talk about variability in presentation, right? Because that's one of the issues that kind of comes up with a lot of clinicians talk to us and say, well, stroke isn't just stroke, right? There's a huge variability in the presentation of someone who's had a stroke. So sometimes it's hard to really pinpoint exactly what the intervention should be. Lack of funding knowledge. This is a big one when it comes to this population. Client and caregiver buy-in. In one of the case studies, we're going to talk about that because it was a really interesting thing that happened when we went back to follow up with the client. And then also, we want to hear from you. What other things do you think are barriers? So variability in presentation, like we said, there's a huge variability in what someone will present like. You might have someone who's ambulatory or non-ambulatory or aphasic or nonverbal completely. There's so many different things. And I think we kind of get analysis paralysis. Well, what if in 6 weeks they're better? What if they get recovery? But what if they don't? So we're providing equipment for these what ifs. We need to be able to make predictive decisions and not just say, well, they might get better, so let's not provide them with the most appropriate equipment for now. Let's think about down the line. Anything?
Well, again, we have to think about what is the presentation that we're seeing. Is there cognitive impairment? Is that going to be a barrier to them utilizing the equipment properly? What other comorbidities, right? We know, especially with stroke, there are so many comorbidities that can maybe impede what is going to be their long-term success or their long-term recovery. And so keeping those in mind, I think can help us maybe look at that crystal ball. It doesn't matter where you live or where you practice in basically the world. We all face very similar challenges, whether it's access to equipment, funding, et cetera. And almost every model expects us to kind of be able to do a little bit of predicting. So, if you're new at this, welcome, and you have to be, reading crystal balls.
Yeah.
But
I also think it's important to remember that when you do read the research and it talks about recovery from stroke, it talks about recovery, but it also talks about symptoms continue to evolve over 2 to 6 months. And it can be, they decline over that period as well. So we really have to keep that in mind, especially when you start talking about tone and things like that.
absolutely. So we're going to introduce one of the first cases. So this is Dennis. I just want you to meet Dennis. And Dennis was a case that I ended up working with the ATP from NSM Troy, Dave Haas, and Diane Thompson from the Rehab Institute of Michigan. So just wanted to give them a shout out for seeing this client. But this is Dennis, and interesting way that I even interacted with Dennis is Dennis lives with his son, who's a pediatric physical therapist that I used to work with in practice. And this was still what he was prescribed after his stroke. His son, who's a pediatric PT, provides equipment quite often to kids with disabilities and doing all those types of prescriptions. But when it came to his dad and having the stroke, it's like, this is what they offered him. So this is what he assumed was all that he was going to be able to get. We've, kept in touch over the years. He actually reached out to me when his dad had the stroke. We had, a brief discussion, and then happened to be locally speaking at a regional education thing. And Dennis's son was there, and he came up to me. He goes, you know what? After listening to what you're saying about proper positioning, center of gravity, independence with mobility, with manual wheelchairs, he goes, I think maybe we should see if we can get my dad a custom chair. I was like, yay, finally. So, so anyways, when I met Dennis, he was 76 years old. He'd had 2 strokes. And he was 4 years out from the initial strokes. And so he was referred for that new lightweight or ultra lightweight manual chair The client goals, obviously better positioning. I mean, he does look very happy and he's a very happy person, but not well positioned and not super functional even in that. And so the caregiver goals, obviously the same. So this is his current equipment, 4 years out.
Yay.
Been sitting in that. Raise your hand if you've seen this in any, exactly, right? So of course I have a very, how would we say it? Expressive face. I do not have a poker face. You pretty much can read everything that's going on in my mind. I know I need to work on that, but I think at almost 50 years old, that's not going to change.
I can confirm that.
Yeah. So anyway, so he came in and I'm just like, oh, wow, that looks really uncomfortable. But you can see we've got some hammocking going on there. That arm support is just, top of the line. That sling back is completely worn. And so you'll see we definitely had there's nowhere we can go except for up from this piece of equipment. I think all of us can agree with that. So this is his functional status. And so he stand pivot transfer with kind of standby assistance. He can ambulate this really short distance, maybe 10 to 25 feet with a quad cane because he does have that right upper extremity hemiparesis. Foot propels his wheelchair. But he had literally fallen just, I think, that week that he came in, falls quite often. And so the thing that we want to say is, would he qualify for funding for a better chair, better in your area?
How many of you think yes?
Wonderful.
That is a great raise of hands.
Right.
Because I think what on there might flag. How many of you are ATPs in here? Does anything flag you on here to say maybe they don't qualify?
4 years.
4 years. Anything else? The other thing we always hear, including from therapists, but he walks 20 feet.
Yeah.
I know. Wait, we're going to talk about it.
Thank you.
Thank you for your enthusiasm.
We appreciate that. I like him. He's like me.
Yes. You and Christy are
kindred spirits.
Kindred spirits.
Go back in there. Oh, and you're going to go backwards.
Oh, Christy's voice.
All right. No. We do not want to hear Christy. We all know that. You can already hear me here. I don't know how to take it down on the PC.
Just turn down the volume.
Turn down the volume.
Oh, his didn't do it.
Okay. Yeah. We don't want any volume on any movies, just so you know.
I think
because you will just hear me in every single one of them.
Now we missed the movie.
Yeah. Go back in there. Oh, and you're going to go backwards. So because of the weight distribution in that chair, the inability to make any adjustments to the center of gravity, the only way that he was able to propel himself was backwards. So not only is he barely functional with ambulation, he's seeing the world in reverse, which is going to be pretty challenging, I think, for him in all of these types of areas.
So this is the interesting areas, the lack of funding knowledge. This is what we see. So one of the first things I hear from everybody, well, they don't meet the diagnostic criteria for a wheelchair. Is there a diagnostic criteria for a wheelchair? How many people think there is in the US? No diagnostic criteria. You have to meet certain functional criteria. In the US, there is diagnostic criteria for seating, but not for the wheelchair itself. So I think that's the first hurdle to get over. Do you want to continue?
Yeah. And I think just looking at it again, outside of just the US centric model, it really does come down to what is their functional ability, how do they qualify. Unfortunately, there are areas of the world where pretty much once you are over the age of 65, you don't even qualify for anything. So this is a really, really big challenge, I think, globally, for us to make sure that especially our elderly clients actually have access to this, stroke clients especially as well. But then this functional ambulation versus assisted ambulation, my friend here very much agrees that if they are not independent, then yes, they do qualify. We do, as Tina already brought up, we have to prescribe for what we see now. We do have to kind of take that little crystal ball and say, well, where do we think they're going to get? And you know what, if we're wrong, if 2 years from now, they're completely back to their pre-illness, pre-injury status, That's fantastic. Doesn't mean that what we prescribed wasn't appropriate at the time. And probably if that does happen, it's because they had good support, the ability to maintain mobility and these types of things in that type of stuff. So
Yeah, and we always say the ambulation thing is actually a big thing. And when you look up what is functional ambulation, no one really likes to say what it is. I've always used the guideline about the ability to cross a street because there's a lot of weird research on crossing the street, whether it's rural, city, downtown Pittsburgh, um, maybe some places like I lived in Boston, you might want to run across the street. But that's kind of a safe speed to be able to do functional tasks. There's also different like tests that you can do. Like how long does it take them to go 13 feet?
yeah, I was actually gonna
We were going to
measure
measure
this
it out.
out, but I forgot. And Saturday morning I couldn't remember it. So if anybody wants to
Yeah.
walk it off, but that's it's a pretty decent pace. And I don't know about you. I have aging parents. Neither one of them would be safe crossing the street ambulating,
Yeah.
right? In any stretch of the imagination. So all of this is in the references. If you want any of these tests and measures, they're out there and they're available for your use as well.
So they say it's about 1.1 to 1.2 meters per second. So for those of us in the US, about a yard and a half, so about 6 feet per second. That seems like it should be easy, but for these clients, I can guarantee you that Dennis,
So
even though
6 foot table, right?
yeah,
Right?
Dennis wouldn't make 6 feet in
No,
1.2 seconds.
no. I mean, I can do that obviously, and I have long legs. So
Yes. There's also, you look at this, this is one of the scales of functional ambulation. And have you ever used this, the FAC? It seems like it's pretty commonly used, but it's really simple to score it. It has very specific categories. Now, it doesn't say functional versus non-functional, but what the research shows is when they are scored on this, anything higher than 1 is considered is usually non-functional ambulation. It hasn't been studied that much, but most of the documentation shows anything higher than 1 is non-functional ambulation, which 2 is ambulator dependent on physical assistive devices, but they require intermittent or continuous light touch to assist with balance. So min assist. So there is good documentation. There is things that you can document to provide to funding sources to say, this is a score. He is non-functional. He doesn't meet these criteria.
100%.
Yes.
Oh,
Yes.
agreed. Correct.
Right. Yep. Yeah. So
100%.
quality of gait, but and think about where we train people with strokes to ambulate. Where is it?
Parallel bars, nice
Parallel
flat
bars,
surface.
shiny flat floors, no thresholds, no carpets to
No
trip
throat rug.
over. Yeah. So consider that. Don't be afraid by, oh, my patient ambulated. My mother had a knee replacement and then fell and fractured her opposite hip, and she was in rehab. And when she was leaving, I said, well, are you going to provide her at least a rental chair? And they said, well, no, she walked 50 feet with the therapist holding her.
Oh, dear Lord.
And they considered her a falls risk because she fell and broke her hip. And they never let her even walk to the bathroom by herself.
But
And they
you
were
can go
just going
home
to
and
send
be
her home
alone.
with no home health or anything. So it's something that's pretty predominant.
So here's a little closer up shot of Dennis's arm and his arm support there. So I think I have all sorts of concern when it comes to this. But like Tina said, just with her mom, what's the assumption of need or there's no need, right? Do we really need better upper extremity support than this? My thought is, and I think he actually did have some bruising, possibly some scraping on the under part of his arm from that position. Decreased sensation, he's at huge amounts of risk for just skin breakdown, much less things going on in his shoulder. Like we have already brought up, what are the presumptions of funding and what attention are we giving to that upper extremity for our stroke clients? So in the evaluation for Dennis, again, as we're kind of working through that, is we had to look, we got him out of his existing equipment, right? There was no way that we were going to be able to see what were his capabilities in that chair with the sloping seat, the hammocking seat, and the back support that was completely worn out, right? So we did see that he does have a reducible convex left scoliosis and a left low pelvic obliquity. So continuing to always be educating as we are doing evaluations. It's, hey, you know what? I think that Dennis needs a little bit more support than what that sling back has been able to do for him. He also had that more flaccid upper extremity. You can see him in the picture there on the right. He's holding that hand in place, but he has pretty good seated balance. And so that was a good indicator that he was going to be successful if we could get him better positioned within that seating system himself. Let me see. Okay. So how do we select the most appropriate mobility base? So you can see the picture there up on the top is him in his existing wheelchair. The one on the bottom is the demo that we brought for evaluation purposes. So for someone like Dennis, being that it had been only 4 years, and most of the time in a lot of areas, we want equipment to last for 5 years unless there's a dramatic change in function and condition, which there wasn't. But I think if you have the right team, which we assembled the proper team for Dennis, an ATP who was willing, the rep who was willing to push through, a therapist who really knows her stuff and was willing to write the documentation, the family who's willing to kind of wait for the funding and these types of things. So we were able to do that. And these were the justifications that we would use. So adjustable axle. We know that on that ultra lightweight chair, you've got that adjustable axle. We're going to be able to get that wheel underneath him. Did you have a question? Oh, sorry. We're able to get that wheel and that center of gravity much more up underneath him. Seat to floor height. That's another big thing with this, and we'll talk a little bit more about some of the seat to floor heights in our next case example. But we're able to get that back angle a little bit more closed using that rigid back and significantly lighter weight. So these are all the things that we were able to use with the justification. And we did the trial, right? So if you can do the trial sometimes and say, hey, you know what? He went X amount of distance in this much time in this, optimally configured chair versus what he's able to do in this one. How about the fact that he's able to go forward in this chair and this chair only reverse? I feel like that's a pretty big functional improvement. I mean, that's just my own personal.
Even if you take those walking speeds we talk about, apply that to the wheelchair.
Exactly.
Because if he can't go the same speed even in the wheelchair, then there's something that we need to address.
Absolutely.
Oh,
yeah. Getting a wheelchair evaluation is not top priority, is getting them out the door. So just stating that fact that they did not have formal wheelchair. Correct.
That's a really good point. Yeah. That's a really good point that we're getting people out the door so fast in some cases that they're not actually having a true wheelchair evaluation.
And I think one of the greater challenges, thank you for bringing that up, is that a lot of maybe hospital therapists, families themselves, they have no idea that something even exists beyond that chair that Dennis was given, right? Even Dennis's son, who's a PT who prescribes equipment for kids, didn't realize that his dad could qualify for something better at that point. And so it's a huge disservice, I think, with the geriatric population specifically, that they don't know the access to proper equipment.
Yeah.
Getting them out so fast.
Yep. And we'll also talk later about there's kind of a resistance to it as well.
Very much so.
Yeah. Oops, sorry.
Very much. So I think we've covered most of these. We definitely need to know that these are some of the other justifications. Yeah, we use the specific things that we can do with the equipment, but the time, the safety, how far can they go? Are they independent versus dependent? Can they do the ADLs that they need to do? If Dennis has to try to do ADLs from a standing position with a quad cane, well, he's going to have to let go of that cane to do anything because he doesn't have a functional upper extremity. And then what's going to happen? Falls. right? So that's not really functional.
And make sure that your clinical documentation, so whether it's an inpatient or outpatient, that your documentation matches the documentation for the wheelchair provision. There shouldn't be a disconnect between that patient's chart and the wheelchair evaluation. I think that's something that sometimes is missed, or we're not documenting everything because we consider that wheelchair evaluation like separate. But the chart should basically follow that and say the same things. Make sense?
And I think we all love those electronic medical records that just get automatically checked and they'll say normal range of motion, normal strength when we know it's not, but
Yeah.
we know that that does happen as well. So I think specific terminology is helpful as well. It has to be very specific to that user. Using generic, I know we've had the AI discussion, and I think that there is definitely a place for all of that. But we do have to, and unfortunately, not unfortunately, but we do have to make sure that whatever it is, even the wording that we're using is specific to our client. I can't say that Mrs. Jones needs an ultra lightweight wheelchair so that she can, I don't know, just something generic. The brain shut off, so I'm going to just go back for
Well, like if you say you need it, you can't just say they need a wheelchair because they had a stroke, right?
Exactly. That's it. That's what I was
Yes.
going for, Tina. Thank you. Thank you. Also, we have to always rule out those lesser costly alternatives, right? I think we did that very well with Dennis. This is not working for him, right? We tried and failed, or we considered and ruled out. And then the why, right? Is it pain? Is it deformity or asymmetry? Is it endurance, safety, these types of things?
I think also remember when Christy just said considered and ruled out, that is enough if you are the clinical person documenting it.
Correct.
It doesn't mean you have to try 10 different wheelchairs before you get to this chair, right? You know your clinical knowledge, you are the expert, so you have considered and ruled out. So it's not just you have to try everything below that.
Yeah. And
'Cause
then
I think there's a misconception
that
about
functional
that.
ambulation, right? We've given you some resources for that, so I think that's really important.
The other barrier that we see is actually client and caregiver buy-in. So when we show you the next case study, there was a lot of this that went on. The family really needs to understand the significance of what you're doing and the benefits and what the long-term implications are if they're not using the equipment appropriately. And also dispelling some myths, things like cushions. So in the case that we're going to see, we went to do a follow-up and we got her chair out to get her in it. She was sitting in a recliner, and the cushion that Christy provided wasn't on it. It was a donut cushion. Now, I come from a wound care background. I about lost my head. And they said, well, my sister works at a long-term care facility, and she thinks this is softer and is more appropriate. She's not a clinician.
Nope. Social worker.
Yeah. um, Restraints.
Oh, yes.
In the
This is a
same
big one.
case,
Same case.
we had provided a 90-degree belt so she could safely foot propel. She had no movement in her upper extremity. She was really good at foot propelling. And again, they came back, oh, no, no. My sister said no.
It's a restraint.
That is a restraint for mom. But she could undo it and latch it herself. And she was at home. So there's a lot of misconceptions that people have based on maybe outdated knowledge or where they might work. Or the whole idea of hard versus soft for comfort. Just because something is firm doesn't mean it's going to be uncomfortable, whether it's hand splints, wheelchair cushions, things like that. And you really do need to provide frequent and repetitive training, unfortunately, and make sure that all family members, if there's multiple caregivers, are trained, as well as the client themselves. Like in this, yeah.
Even the buy-in from the client, right? Working with this population, I am, in the phase of my life where I'm caring for my parents who are aging. The resistance that they have to using any type of assistive technology is a barrier that we all have to get through as well. And I think we run into quite often with our clients and our patients that we're trying to give better equipment, better support, and better mobility but they just can't
Yeah.
grasp and go beyond that.
My mom is 88 now, and so it's been almost 10 years since she had her hip fracture, but she's had a total of 3 knee replacements because she had one redone, a hip fracture. She had a shoulder fracture. Like she's very osteopenic. She still ambulates, but she won't use her walker unless I am there and make her. And you know why? I don't want to feel old.
Yeah. Those are for
And
old
now she'll
people.
accept that. I'm like, but mom, you are old.
Oh.
But it's really funny. And all her friends are the same age. Oh, I don't want my friends to think I'm old. Okay, well,
Right. Yes,
yep.
please. Oh,
Yes.
huge.
Yes. Yeah. Yeah.
Exactly. Thank you.
Age shouldn't be a factor.
Right.
It's about function. And we might not do it on purpose. But I think when you look at some of the disparities, I think sometimes it happens.
Yeah. So here's Dennis on delivery day. So the therapist and the ATP, they did all of the things that they needed to do, and we got the funding. And there he is in his new chair. I'm going to show you the video next, and we're going to go a little bit more deeply into the specific equipment as well. But yes, he was backwards. I'm like, Dennis, I know. So he is going to turn around here in just a second. And here he's grabbing his actual pelvic belt. He could not believe that he needed a pelvic belt. He's like, why do I need this safety belt? And, you know, this is the clinic where he's at. Everyone gets anti-tippers and a belt, which is totally fine. And then what was quite funny was he just could not get over the fact that he had to have a belt on his chair. And I got a message from his son, I think the next day, and he was telling me how much Dennis really liked that positioning belt when he got home. And so here he is on the right. This is his at home. This is one of the things, again, still trying to kind of work with that, but he had pretty significant threshold there to get into his bedroom, which is how he started to kind of, or where he really started to be using that backwards positioning. So,
and it's pretty tight.
Yeah. We're going to get there.
We'll get there.
Excellent. So what other barriers do we see? I think Julie named one of them for sure.
Anybody else? Any other things that you think are barriers to equipment provision?
Yes.
Yes?
Yep. 100%.
Funding sources?
100%.
Anything else?
Oh, yes.
Yes. The whole perception that you're giving up because you're providing them a wheelchair. Yeah. Yeah.
Yeah.
Yeah. So when there's that transition, when maybe they're going to long-term care and the equipment isn't provided correctly, and there's something missed in that transition. Maybe someone's not actually doing the documentation, or the documentation's not getting forwarded on. And long-term care in the U.S. does provide different challenges than it does in other places.
Yes. 100%.
Yes.
Yeah.
Yep.
Everyone should walk.
Mm-hmm. Yep.
Yep. Yes. Huge.
Yep.
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 Yeah.
So physician education, did you guys hear that? That can be true. There's some physicians who are really involved in seating and wheeled mobility, but they're few and far between.
Yeah. Yeah. This one.
Yep.
Mm. Yep.
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 So that idea of the 24 hours, what happens when they're not at their peak in our clinic?
Yes. Yes.
Yeah.
Home
Yeah.
accessibility. Absolutely. Absolutely. Yeah, the example that we'll show here in a minute, they didn't have a ramp when they first went home.
Yeah.
So,
So you guys came up with actually more than we did because we
yeah.
just kind of popped some up just in case no one wanted to talk.
Yeah.
Also, therapist knowledge of options. Again, education, untreated psychosocial impacts of stroke.
Depression.
Yeah, the case that we'll talk about, that was a real issue, actually. That became clear to us just on a visit to her. Oops.
Yep. So here we're going to just share Nancy's story. So Nancy was 80 years old when she had her stroke. Actually, she had her 80th birthday, I think about 2 weeks after her stroke in the hospital. We kind of went in to see Nancy about 4 weeks, we being me and
Yes.
Tina via FaceTime or something like
Yeah.
that. Previously, she was independent, living alone, doing all of the things, cognitively intact, and was ready to discharge home. Nancy happens to be my husband's aunt. So this is how I became involved in this example. So what are some of the problems that we see? Tina's going to kind of go through some of the things that she saw, because of course, as soon as I saw it, I was like, Tina, I think this person actually needs a body point dynamic arm support, which is what we're going to go into, which is how we kind of came together to build this presentation.
What do you guys see? No shoes, yes.
No shoes.
No shoes, yes. Yeah. Too wide.
Sling seat.
Sling seat.
Oh, come on, that fits her perfectly. Look at that seat to floor height.
What? Yeah,
Gate
a gate belt.
Yes.
Sling. Yep. Yep. And even like there's a pad at the top of the cushion that drives me crazy. Because she didn't having, yeah. So there's a lot of problems, right? This is something that they provided in rehab, but they did expect her to kind of function in it while she was at rehab as well.
We'll show you a video of that in just a minute.
Yeah. So really, no or inadequate upper extremity support. Even her other arm couldn't really rest comfortably because it was up here. Poor fitting wheelchair, obviously.
Understatement.
Really no postural support. She was just kind of left to fend for herself. And really, that particular wheelchair frame had limited or no adjustability. Right? So it's all of the things that we typically will see with just a standard hospital chair or hospital issued chair. Functional status. She was able to foot propel, believe it or not, even with that horrible chair.
Well, here's a video of her in that chair.
Crying. And she's frustrated.
She's very frustrated. If you could hear hear her saying, she's like, I can't do it. And then her daughter is on there saying, can you just do it? Christy just said, please just do whatever you can. Because of course I wanted it for the presentation. So, but then, and this was about 4 weeks into her stay. She, it's too wide. She can't reach that. She's not able to, kind of get her. All of these things are horrific, right?
But she has shoes.
Right. So she has shoes. So here was when we went in to do the team evaluation. So again, doing what I do, I wasn't going to let her go home in just a 16 by 16 sling back, sling seat with elevating leg rests, because this is what the therapist told me they were going to do, and just an arm trough. I said, I don't think that's going to actually work, because again, she was able to do it. So up until this point, when we brought in the demo to do the evaluation, she was max assist of 1 to 2 people to take about 5 steps with a hemi walker. So not very functional, right? And she wasn't functional in that wheelchair. So this was kind of her first independent mobility that she'd had since she'd had her stroke.
And the thing that is concerning is that there wasn't the thought process that, oh, she needs more.
Right.
Right? They were prepared to discharge her with something similar to what we saw her in first.
Maybe it would have fit her a little bit more in width.
Yes.
But, and so this is where I just wanted to kind of really quickly tell you a couple things. So your standard wheelchair, so this is one of the reasons I think, and one of the justifications that you can get for those ultralight wheelchairs, is you can get it back down to an area where she could actually foot propel. So, I mean, if Tina and I stand next to each other, I'm a bit taller than Tina, right? If we're both going to foot propel, nice try. If we're both going to foot propel, Tina probably needs it a little bit closer to the ground than I do, right? And that's the case with Nancy. Nancy's probably just a little bit shorter than Tina. A standard wheelchair seat to floor height is 19 inches. That's without a cushion, 19 standard. The Hemi Hemi-height wheelchair, so in the States, this would be a K0002, is 17 to 18 inches. That's still really, really tall. That'd be way too tall for Nancy. And then that lightweight chair that she was in, which is that K0003 in the States, or the lightweight, is 18 to 20 inches. So this is nowhere near anywhere appropriate for foot propelling, right? Because if we don't get it down, we're going to have all sorts of issues with lack of independence with that. So here she is, discharged to home. Love that sling and that pillow. It's fantastic. Thankfully, I did have a wheelchair that I was able to loan her. So this is how she got at least something decent to be using for her home. We're waiting for the final equipment. And she was discharged with a resting hand splint.
Which they didn't
They didn't
utilize
like
because
it.
they thought it was too hard.
Yeah. So.
Go ahead.
So this was the final wheelchair selection. It was an ultra lightweight wheelchair. We were able to, we initially set it up at 16. We ended up dropping it down to 15 and went from actually a 24-inch rear wheel to a 22-inch wheel to get her in a better position for foot propelling. So that's kind of the overall thing. And then Tina's going to go into some of the upper extremity stuff.
Yeah, so you guys asked about the upper extremity. So one of the things is I've done a lot of research recently, like trying to find out what's available for upper extremities. And full disclosure, this product is a Body Point product, but there's other products out there too that are better than a sling.
And a pillow.
Yeah, and a pillow. Really what we were trying with Nancy was to get improved hand function and also to get some function back for Nancy because she did have some movement in her shoulder. You had to kind of encourage her to move.
Yes.
But she was really excited when she did have active motion, and it really helped her kind of mood. Also, we want to protect and provide protection for the shoulder. If you look at the research on upper extremities, 85% of people with strokes, whether they are ambulatory or non-ambulatory, up to 85% have subluxation or shoulder pain. So it's really important that the upper extremity is protected. Also, where do you tend to lose the range of motion? You tend to lose external rotation and abduction.
That sling was really keeping her in a really optimum position to maintain her range of motion.
So even if someone doesn't gain motion back, these motions are important for things like putting on your shirts, cleaning under your arms, basic functions that can really impact people over time. I like these videos. Let's see if they'll play.
Yep, so if you get your
So this was
elbow back,
Nancy.
there
You can
go.
see her hand. This is only a couple of weeks after she was discharged.
Mhm.
You can see already that her hand is starting to tighten. She had full range of
Yep, just gotta
motion
bring your arm back a little
when she was
further.
in the hospital, but already without proper support, you can see that she's starting to have more tone in her upper extremity and her hand, and it's a little harder, but she was able to place it onto the hand support. And then I like this one.
Push the thing
So
back
she
up.
wasn't able to initially do external rotation.
Now you can
Now bring it back
in
in.
yourself.
Nice.
And we don't have the volume on, but I love her exclamation. They were like, oh, she's like, oh, wow. I don't want to get too excited because I don't want another episode. But you can see the smile on her face too, right? She's more comfortable. She's able to do things she thought she couldn't do. So I think that is really important. And also to make sure that the height is right when you're going to provide that kind of support. So you do also need to think about ultralights and lightweights because they have adjustable armrests.
Way more adjustability.
Final equipment, so postural support things we also did for her. A BioFit wheelchair cushion, so not the donut.
Not the donut.
Not the donut. We did a belt at 90 degrees because think about when someone foot propels. Everybody's worried about safety or people sliding out of the chair. Remember that you want to support in front of the trochanters to prevent sliding, correct? Think about the rotation of that. So at 90 degrees, it still lets her pelvis rotate forward and backward to foot propel, but it keeps her back in that position at rest. And it makes her feel more secure. Does that make sense? Because we always talk about like, get a really good support. And you want to also be careful with the cushion that it's not too supportive, because to foot propel, you do need to move your pelvis. And I think sometimes we forget about that. We want to consider friction and shear a little bit, but we do want to make sure that they actually have pelvic mobility within that seating system and that they don't have to slide out. Usually when I see someone sliding out because they're foot propelling, it's because the seat to floor height's too high or the seat depth is too long. So they're having to scoot way forward to get their heel down, and now they feel like they're falling out of the chair. So all of these things are really important in combination with each other. One thing by itself isn't going to do it.
All right.
So, inappropriate equipment, how do we overcome some of these roadblocks? I think we first need to determine what is appropriate equipment and what defines that.
Is that me?
Yep.
Okay. So obviously, does it meet their needs, right? Whether it's their functional needs, their health needs, ADLs, and is it going to last over the amount of time? So if you think of Dennis, it was not lasting really over the time that he was needing it. Looking at, again, just looking, trying to do some research for this, we found one study, I think it was out of
In Turkey.
85% of patients with a stroke use an inappropriate wheelchair in this study that was looking at that. I can't remember the end, but it was actually a pretty decent high end.
Yeah.
And so obviously the recommendation is that we should be doing individualized prescriptions. That's best practice. We all know that. Unfortunately, it's our geriatric, our elderly, our stroke clients who quite often don't get that. And we know that inappropriate wheelchairs can cause more problems, not only physical, but economic and psychosocial. So if Nancy had been left in that wheelchair that was there on the right, it would have been significantly worse, even with than what she had. So I think good stuff there.
And I think it's also important to remember, even if there's funding challenges wherever we are in the world, it's to not be okay with saying, well, that's good enough, right? We hear that a lot. Well, that's good enough. We can get this faster. That's good enough. Yes, sometimes that is our answer, but we want to be careful that that's not always the answer.
And I think in the case of Nancy, this is my family member. So of course I'm going to try to treat her and get her the best as possible. I think if we all kind of go into that with every one of our things,
Yeah.
we can, do as best as we can.
And it is to say both these case studies, the equipment was fully funded. I think that's an important thing to bring across, is that it wasn't just because Christy or I intervened or had access to equipment. It's all went through regular funding channels.
Yep.
You do need to start, obviously, we're just going to review some of this with a good foundation, right? The way Dennis started wasn't going to help him long term, and it wasn't helping. So it's just remembering you still go back to the basics of your seating and positioning. Oops. Looking at primary postural supports, you start with your base, then you build up from there. So whether it's a cushion or a back, knowing what you want that equipment to do and how it's going to facilitate postural control and function. Again, like I said, if someone's foot propelling, you don't want them to be over supported so that they can't actually rotate their pelvis, for example. Or you don't want the seat to floor height too high. But allowing movement within a functional range. I think a lot of times we think of seating as this static thing, and we forget that people move in that position all day long. Trying to keep us on time, guys. Sorry.
We're doing good. We're good. Keep going.
Considering secondary postural supports. So things like pelvic positioning. Do they need trunk support? Do they need chest support even in some cases? Okay. And also just make sure that the upper extremity, especially with stroke, is supported. We want to try to prevent some of those problems that happen over time. Again, I want to go over a little bit of the upper extremity because I think this is the area where we forget with stroke patients. Even if they get an ultralight wheelchair and they can foot propel, oftentimes we end up with clients who are here, right? You even see ambulatory clients that are here. They have contractures in their hand and their wrist. They're unable to use that upper extremity. And again, in a review of studies, shoulder pain evident in about 84% of clients with stroke. And again, it's not just non-ambulatory clients. Shoulder pain after stroke isn't usually immediate. If you look at the studies, it develops within 2 to 6 months after the incident. So we almost have to assume that if we don't support properly, there will be a problem down the line. 84%, that's a pretty high percentage. Um, also, they talk about using active exercise to really kind of help facilitate recovery. You can use an arm support like this, actually has 60 degrees of active range of motion. If any of you saw the poster presentation done by Erica, I think it was on Thursday, she's actually utilizing the dynamic arm support on an office chair for her ambulatory stroke clients with subluxation to actually facilitate active exercise in conjunction with functional electrical stimulation. And she's having really good success. So there's lots of different ways we can facilitate protecting the upper extremity and actually helping recovery. And again, I always say it should start immediately post-stroke. All of the research says the second you see any upper extremity involvement, start thinking about what you're going to do to intervene and start intervening.
Don't just put it in a sling on a pillow. Yes, Sheila. Yes.
Yes.
Yep.
Yeah.
Yes.
Yeah. Yeah.
Yes.
Yeah.
Good
So
point.
the position, the surface, the height is really important. So no matter what arm support you're using, is making sure that it's in there correctly. They're not in this position, and that we're actually putting the shoulder in the position of more rest. If you think about how many of you remember the open packed position of the shoulder? Anyone? So it's here, right? We're not going to achieve that in a wheelchair, but we can try to get close to that. We want to take some of the pressure off the rotator cuff and the muscles. If it's caused by tone, there might be different things we can do. But remember that shoulder pain could be caused by tone, previous injury, just lack of muscular control. There's a lot of different reasons why you develop shoulder pain. So we also need to remember to evaluate that.
2 more slides.
Oh, yep.
3 more minutes.
We already went over this, right? I know. Sorry.
We just like this.
More
We think
slides.
it's a good. We think it's a good
A
example.
good picture of remember where that range of motion is usually lost in the upper extremity. So
Last
what do we
one.
do? Yeah,
What do we do?
look at that. So how do we prove in the clinic? I know everybody hates me here to say keep up with the research, but come to places like ISS, just read. I read abstracts and then decide if it's relevant to my practice. It's not like you have to read a journal cover to cover, right? There's lots of good online resources. Providing the most appropriate equipment, focusing on the upper extremity, and education. Don't forget about the education, and encourage conversations within your workplace or within your community of therapists about what is best practice. And also documenting what your best practice is and remembering that your experience guides best practice. It's not just something that someone writes up in a research project. It really has to do with your experience and the outcomes that you're seeing.